We have one talk by Dr. SUDEEP. Dr. SUDEEP is an intensivist. He was pediatric intensivist. He was trained here at Kanchi Kamakoti Child's Trust Hospital, and he's further trained at Australia. And now he's come back to join as a consultant.
Hope I'm audible. I'll try to be short, and I would like to thank or acknowledge my department and Dr. Thiru, and I would also like to thank Dr. Kalan. He actually gave a decent importance to us, mentioning our importance, and it is the same way as Dr. Thiru treats us. So to start with, I'll go with surgeon's perspective when we go for airway surgery. So I think the most of the audience are ENT surgeons and few are anesthetists and intensivists. So for the surgeon, you are going to give a life probably without a respiratory distress, or who had a tracheostomy are going to give it. So it is really high risk, and it has a game changing thing from your perspective, and I think that's why you are quite invested and airway surgeons are quite invested. And you have a lot of stents, you have a graft, and these things, when you have stent and graft, you are prone to infection and you can have problems. And healing is good in most of the times, but here if you have excessive healing, you may have granulation, you may end up with problems. And to achieve a better outcome, you need decent immobilization. So this is the perspective with which a surgeon starts and goes ahead. Now going to our perspective, as a surgeon you are right, you need immobilization, good healing. As an intensivist, if a patient is immobilized for long and we have a lot of ICU interventions, the patient is going to be a higher infection risk. He will have ICU related weakness, he or she, sorry, and the patient may have delirium, and when we bring down the sedation withdrawal may be there. And actually, on the contrary, you expect the patient to be immobilized. While these things happen, ICU related weakness or delirium, the patient may become agitated and move a lot. So it's going to endanger the procedure. So we have to kind of a balance between these two. And so if there is poor healing or prolonged immobilization, you are going to get prolonged ICU requirement, more ICU interventions. So the patient is going to require more sedation, immobilization, and more infection. So you will get into a kind of cycle where our intention was right, probably a bit too much right, and we ended up on the wrong end. Now I like this slide because as an intensivist I say it's too long, I'll wake up the patient, but as an airway surgeon you say no, he will displace the graft. We tend to pull each other apart, and we should probably end here. Okay, so we will weigh the benefits of waking up against keeping the patient immobilized, and that's how we proceed. And all our airway protocols, airway surgery protocols kind of balance, and this is where, as everyone was speaking, teamwork makes a decent difference. Now going to the proper protocols which we follow in our unit. So prior to the planning of surgery, the airway surgeon, before he fixes the theatre, he comes to us, discusses about the basic pathology of the patient, his plan, date of surgery with a PICU bed availability. And even before he goes into surgery, he will give us a period of tentative period of stay or immobilization, so that we are well prepared and all our equipments are ready. This is even before he puts that into the list. Probably he puts into the list and then comes and tells us. And next, when a patient is coming, after the surgery is done, our surgeon comes with the anesthetist to the theatre, and we straight away start with mechanical ventilation, because so most of the surgeries, I'm speaking of laryngotracheal reconstruction kinds, we start with standard ventilation with a normal gas, targeting normal gas exchange. We send routine post-op hemoglobin electrolytes. Sedation, opioids we use as a first line. Our first line is fentanyl. Morphine is also okay. Our second line is midazolam. We target a sedation score. We use comfort behavioral score, which is a kind of a better accepted score in terms of sedation. You can follow your ICU sedation score. Essentially, the patient has to be decently immobilized. We target a score of 12 to 18 for decent one, and if you feel that the patient has to be strictly immobilized, we target much lesser score CBS less than 10. So speaking of comfort score, lower the score, the patient is too much sedated. Higher the score, the patient is too awake or agitated. And sometimes we may start on paralytic infusion as well. And if you had taken a rib graft, thoracotomy, the patient needs a decent pain control in addition. So in addition to the opioids, the patient may require NSAID as well. And when you give NSAIDs, your opioid requirement goes down. And post-op prophylactic antibiotics, most of the times it's surgical prophylaxis covering gram-positive bacteria. Super surface are standard, but sometimes if our ENT surgeon finds on OPD basis he has a tracheostomy for a long time, he would cover an organism based on the previous secretion culture from his tracheostomy, because that is already colonized. You have a decent risk of infection from there. So that is one other thing. Clear orders regarding the neck position, what position to give, flexed, neutral, and the nurses will clarify whether the patient can be moved, how much can be moved, is there a neck shoulder roll to be kept, neck neutral position, and whether neck has to be immobilized too much or bit of probably 5 degree 10 degree mobilization is okay. And PPIs, as we all do in airway surgeries, anti-reflux drugs. X-ray chest, we have a ET tube in place, or sometimes tracheostomy tube in place to confirm the position, and neck site inspection is done. So as we already mentioned, the surgeon's findings intra-op would have been different, or his procedure would have been sometimes different based on the pathology. So we again clarify regarding the period of immobilization, tentative immobilization, and we go for restricted fluid intake. And the final thing, I feel this is the most important thing, plan for airway emergency. So there is a clear plan on whom to call first, what to be done, what not to be done. Whether there is always a airway anesthetist who is already ready. Any airway threats will be immediately communicated, and there will be a plan communicated. So you can do bag and mask, you should not attempt intubation or something like that. Then those things are clearly communicated on what to do and what not to do. Daily care, there is no change in the neck position or any, even the ET tube movement, if it is high or low on X-ray, will not be done without consulting the ENT surgeon, because it is a high risk and we can displace the grafts, so that has to be there. And this is from our ICU part. You are going to keep the patient probably immobilized for 5 to 7 days. So exposure keratitis, bed sore care, those things make a lot of difference. And your oral cavity has lots of secretions, bacteria. So oral care with chlorhexidine every 3 to 4 hourly has to be done, and rounds are done with the joint ENT and PICU team. Every day there is inspection of the wound, and if necessary, dressing is taken down, redressed and kept it. Drain output, as obviously is there, has to be seen. Sedation requirement may go high, so the patient may become tolerant. We may end up increasing the doses or titrating to other drugs. And if paralytic infusion has been placed, then we use train of 4. So train of 4 is a kind of nerve stimulator to see the muscle twitches, and two twitches is the right thing. So if you stimulate the nerve, you will see the number of twitches in the limbs, and 2 twitches is the right thing. If the patient has 4 twitches, the paralytic infusion is not adequate, and if there are no twitches, the patient has too much paralysis. So we grade, because more the paralysis you give, more weakness you are going to have later. And since with pediatrics we have a higher degree of movement of the ET tube, so we tend to see the X-rays at least every 3 days. Now with respect to nursing care, pressure sore care, so how frequently the patient can be changed position, bowel and bladder care. And bowel, with respect to bladder care, not every patient needs to be catheterized towards the entire duration. Maybe when the patient is on a paralytic infusion, you can keep the bladder catheter in place, or else you can take it off and see as soon as you feel stable and see. And humidification, as Dr. Callan mentioned, has to be taken into account. One thing which when we have problems or overlap of adult and pediatric patients is we tend to use the HME filter only in the ventilator circuit, not the active humidification. For infants and pediatrics especially, the HME filter is not adequate for complete humidification of the circuit. If you don't humidify, you will have a lot of mucus plugs, you tend to have VAP, and those things have to be addressed. You need to have active humidification of the circuit, which comes as a humidifier separate. And even in the active humidification, you have a non-invasive mode and invasive mode. It has to be in the invasive mode while the patient is on invasive ventilator. Neck swelling you would probably do every day. Eye care and oral care, as I have already mentioned, eye care is lubricating eye drops, oral care with chlorhexidine, so you increase the VAP. VAP bundle, if the patient allows neck in neutral position and head end can be elevated, head end elevated 30 degree, you will probably give PPIs, and oral care with chlorhexidine is one thing. So when it's time to wake up, we'll have a plan, probably as we all do. We'll stop paralysis first if it has been there. We'll probably not run paralysis for such a long time, and stopping once at a time, and we'll probably start waking up during a daytime so that we'll know what happens and everyone is there, and we will see how the patient goes. If the patient is too much agitated, we'll also have a rescue plan, what drug to give and when to. And sometimes the waking up can occur in theater, where the airway surgeon will have a look and then feel satisfied, and he will have a smoother wake up when from inhalational sometimes. And since it is sometimes difficult to control children, we will have safe physical restraints in the sense so that they don't pull out the tubes by having splints at the elbow both sides. And the most important thing, it has to be safe, it should not be traumatic for the patient. And for a pediatric patient, we tend to keep the parents beside them in the wake up so that they feel comfortable and not move around and threatened. And if it is a toddler or behavioral abnormal child, we tend to keep some Dexmed or clonidine infusion, which will help in a smoother recovery. So I'll go with respect to disease or few specific surgeries. With respect to tracheostomy, in our unit we give just decent sedation or pain control only on the post-operative day 0. We will awake the patient from the next day thanks to Dr. Thiru's technique, where he gives maturation sutures to us. We need not worry about the stay suture. So he sutures the skin to the cartilage, and even if the tube comes out, the hole is still there, we can put it back. And if you have a stay suture, I think you may have to take it over a graded approach, keep him sedated for decent amount of time till you feel comfortable over the stoma. With respect to partial cricotic resection, with respect to this surgery, you will probably need a flex posture for a decent amount of time, immobilization for 5 to 7 days, and you will have a relook and then extubate. Single stage LTR, here we have the ET tube as a stent. We don't have any other airway, so the airway is much more precious here, and we have a neutral position. And as I mentioned, the airway rescue plan will be clear much more here, because that is the only airway which we have in place, and we cannot meddle because inadvertent movement or intubation can cause displacement of grafts there. Now double stage is probably neutral position is okay, not much different, but still we have a tracheostomy in place in a double stage. Though we speak of protocol, sometimes few kids sound to be different and make us do different things. So this was two things, as Dr. Callan mentioned, he actually showed one of these pictures. So these were two kids who underwent airway surgery, so probably beyond 5 to 6 years, and they understand. So you tell them, communicate to the parent. What we do is we disconnect from the ventilator, where the patient does not need like strict immobilization anymore, but you still need the stenting effect of ET tube. So with nasal ET tube in place, the patient actually can move around. You can see the patient, actually the second one is a girl who is walking, and she was walking the mother. Actually I have cropped that photo. he is playing with the ball, and the first one is the one where he is playing on a video game. I think, as we mentioned, more than 5 years is a decent age. Below 5 years it's probably difficult because they may not understand what you are saying, and this is an extension of what it was done in croup tubes. In croups, where you have a longer tubes, you just have the and then extubate them because they don't need ventilation anymore. But this was done with a normal ET tube with a HME. You need this HME, that is one. And the second thing, you need nasogastric tube for feeding. You cannot feed them orally directly because they still have the leak, or they can aspirate around that. And our anesthetist tells one other technique. If you want to do suction, the patient is awake, the patient may feel quite painful. So if you find a decent amount of secretions, just take 0.5 to 1 ml of lignocaine, instill it before you suction, maybe 30 seconds, leave it 30 seconds, and then go ahead. The patient will not feel so bad to pain. And they do quite well, and the patients feel quite comfortable there. And in a smaller child, this is not in our unit, but in a unit which I worked abroad. So it's a double stage LTR where the patient had tracheostomy. So this was a difficult patient to sedate. We were on 3-4 sedatives, still the patient would move around even prior to PCTR. So post PCTR we had a lot of problem with sedation, paralysis. We have been struggling for 3-4 days. This child was 4-year-old child. So this was a help from orthotics department. So PAPUS, that's what it is mentioned. PAPUS is an immobilization device for infants. So you can see the mold, especially to the neck and the body, and you have a strap kind. So the patient, if it is fixed, the patient cannot flex or extend. So you have a strap kind here. The patient has a tracheostomy. To immobilize the neck, in addition to that, we have attached a cervical collar. So it's a cervical collar with a PAPUS, and this patient, this ventilator was connected actually, and within 4 to 6 hours after giving this, we made the parents sit on side, put the patient on spontaneous. We were gradually able to extubate next time, and this was quite good, I felt, because this is the phone which I found over net, and this was with the help of orthotics we did this. This is an immobilization device particularly used in infantile period. I think that's it from me. Thank you. I like this slide. This is a kind of protocol, but I think each expertise, each place has a different way. So we may say our way, but you need to, or you understand probably the better where you can do and go. So you can have a local discussion with the team. The principle stays the same, but we can tailor it to your expertise or place. Thank you very much.
Thank you, Dr. Sudeep. We've learned exactly what all details you go through in the day-by-day management of these patients.